No smoking. That's the answer to this lecture. But it relaxes me, Kelly. Relax another way. Okay. Let me back up. Let me introduce it appropriately. All right, so respiratory diseases. So I get questions all the time on this class of, I really want to take this class. I hear great things from my friends about this class. I want to be in medicine, and it's super relevant. But I haven't taken 202 yet. So we're almost done with the semester. If you were tasked as an advisement counselor, what would you tell that fellow student about not taking 202 and just jumping into this class? Don't do it, or you'll probably be fine. So, One, you'll be fine. Someone's pretty confident back there. Sounds like the vast majority are thinking it's probably a good advice, right? So, I'm not going to spend a lot of time reviewing the respiratory system like we do with every lecture. We go through a little bit of review. I'm going to do a little bit of review, but I'm really kind of expecting that you already know some of these things because this is a huge component within 202. Same thing next week with cardiovascular, right? I'm not going to recapitulate all the cardiovascular phys that you learned in 202, but you need to know it. And if you don't know it and it's rusty, this is the time to get the textbook back out, look at those notes. Refresh yourself on what it is that we're talking about within this system. Now, the respiratory system, the cardiovascular system are obviously intimately connected, right? And we're already starting to see some things in this last unit of systems that are intertwined. Because I didn't want to leave endocrinology unfinished. Because endocrinology, with our last little segment on diabetes, the vascular issues that we see there are tied right into next week, right? We're going to see that perfusion and oxygenation and distribution of that oxygenated blood today is going to tie into next week. So the things that we're going to cover in this lecture are going to be different categories of diseases. So we're going to look at things that typically go wrong. We're not going to be able to cover all of the different issues within respiratory phys. But we're going to cover a couple of big topics. Atelectasis, pulmonary diseases that are obstructive and restrictive, respectively, and then infections. How many of you have had like a respiratory infection in the last year? Okay. How about the last 2 years? Get some more hands. How many want one? No, I'm just kidding. So these respiratory infections are actually pretty aggressive. And we'll talk about pneumonia, and we'll talk about SARS, and we'll talk about, which isn't really something that we see in this country. But there was a period of time, a couple of years back, where there was like the SARS epidemic, where people were coming on planes from Asia and they were contracting SARS. So we'll talk a little bit about that as well. But before we go there, this is the point where I'm going to make some definitions of these terms. And if this figure is a little foreign to you or frightening, or you've never seen it, you probably want to review it. So this is straight out of anatomy and physiology text. And it's dividing up the total lung capacity, which is about 6 liters. Okay? And lung capacity is completely dependent upon the height of the individual. Most direct correlation is the height of the individual. Not necessarily weight or mass, it's height. So taller individuals are going to have larger lung capacity. Right? So you look at like Michael Phelps. Specifically, Phelps is interesting because his chest is so long. It's not just that he's tall, he's really tall, but he's kind of almost got this enormous chest. And so the size of his lungs are probably enormous. Okay? So he's probably well above 6.2 liters. I bet he's probably 6'5". Does anybody know lung capacity of Phelps? Siri. No, I'm just kidding. I found a new toy that I want for Christmas. Does anybody have that Echo, the Amazon Echo? You have that? Does that thing work as well as the videos show?
Yeah.
Does it help you study for pathology? Have you asked it any pathology questions?
No.
You should. I want to know how it works.
It works basically just like Siri, though.
Yeah, but Siri, like, I don't know, it seems like she fumbles all the time. Yeah.
Google says his lung capacity is
12
12 liters.
liters? No. No, he's a freak, but that's like double freak. That's, what?
Yeah, all of these articles say it.
Can you email me a couple of, I gotta look at that. I mean, if that's real, that guy, I mean, marijuana or not, you should be winning everything. All right, back to the topic here. If you don't know what we're talking about, ask Suri. Okay, so this is 6.2 is typically kind of a normal max for a normal individual. So like 12 is like, I knew it was large, right? But I didn't think it was going to be 2x, okay? So here, this is showing your inspiratory reserve volume at about 3 liters. And then on expiration, right? You have about 1 liter to 1.2 liters that never leave your lungs. Right? So if you do a forced expiration, right? You breathe everything out. There's still going to be a little bit of residual air, called residual volume, that stays in the lungs to keep things from collapsing, which is important because we're going to talk about that in a second. And that 1 to 1.2 liters of residual volume kind of keeps all of your bronchi and all of the alveoli, respiratory tree, all of it open. So that on the next breath, you're not having to sort of use your energy to inflate the balloon. So the analogy would be like if you pull a balloon out of a package, right? It's like all squished up. You inflate it once and deflate it all the way. You can never get it squished up again. Does that make sense? Like you put it on the table and it's kind of like partially inflated, but sort of not very big. So that's the residual volume that's in that balloon. So the moment you blow it up again, it's more efficient than that first time. And so that's why we have this residual volume. It keeps these things open. Okay? We still agreeing with that 12 liter number? Yeah? Man, Google's crazy, man. That's amazing. Phelps is even crazier. All right. So then the expiratory reserve volume is about 1 liter. And then right here, about half a liter is where you kind of normally just breathe in and out. That's your tidal volume. That's not why you're running. That's not even why I'm lecturing, because I'm breathing out most of my air and then I'm breathing in again. So this tidal volume of about half a liter is your comfortable breathing right now. That's what you're moving, somewhere in that range. Okay? If you're a shorter individual, it's going to be smaller. If you're a larger individual or a freak like Phelps, then it's going to be an enormous number. Okay? I still can't get over that. I mean, has it blown you guys away as much as it? Am I the only one that thinks this is crazy? Like, he is a... Like, why didn't they do like a 60 Minutes on that? That seems like a way better story. How tall is he? Suri? 6'3"? I mean, that's super tall for me. But... All right, let's talk about some of these terms. So he has a. If you look at film of him swimming, like his chest comes out of the water, and it's like a whole person standing up. He's like, geez, and there's legs back there doing stuff, right? Flopping around, beating everybody in the world. All right. Yeah, some of these athletes are just incredible. Kobe's retiring. You guys see that headline? Some of you guys hate Kobe, I know, but just from an athlete standpoint, I mean, just incredible athlete. It's amazing to watch some of these athletes perform. You watch some of the film, the guy lights up for 81 points in a game. Did you guys, anybody watch that game? That game, I'm not even a Laker fan. Like I only am in awe of Kobe because he's just so amazing as an athlete. And some of you probably think that it's amazing it stops right there, and that might be the case. But he was just unconscious. He was like, he couldn't miss. It was pretty crazy. So, all right, I'm way off topic. Let's talk about eupnea. So eupnea is a Greek terminology, from the Greek, meaning well-breathing. The U means well. So well-breathing. A dyspnea is a shortness of breath. And then orthopnea is shortness of breath while you're lying down in a horizontal position. So these are all review terms that you should know. But if you don't, we're capturing right now. Hyperventilation versus hypo. Hyper meaning ventilating too much. Hypo meaning underventilating. Hypercapnia versus hypocapnia. Hypercapnia is referring to CO2 in the blood. So hyper would be high, hypo would be low. Hemoptysis. Hemoptysis is when a patient coughs and the sputum comes up, there's blood in it. So coughing up blood would be hemoptysis. Cyanosis. This is when a patient becomes slightly blue in color. Usually there's a decrease in oxygenation of the tissues. We'll see patients later today in our lecture called blue bloaters. They're cyanotic. And hypoxemia is a decreased oxygenation of arterial blood. And hypoxia is a decreased oxygenation of the tissues or the cells. So hypoxemia is referring to the oxygen content in the blood being low. Hypoxia is referring to oxygenation at the level of the tissue of the cell being low. Now, there's another term that's not on the screen that I should characterize or define. We use the term ischemic. So how is that different? Ischemic is actually referring to blood flow, not oxygen. So if a tissue is ischemic, that means the blood flowing to the tissue is compromised, and it'll probably become hypoxic. Make sense? Okay. So hypoxemia and hypoxia are referring to O2 levels, oxygen levels, and ischemia is referring to blood flow. Okay, now that we got all the review stuff out of the way, and we went around the globe with 2 different sporting events, let's talk about our first disease, which is atelectasis. Atelectasis is lung collapse, simply put. Lung collapses because it doesn't expand appropriately, and this is going to cause a reduction in oxygenation. And so you can have this occur via a couple of different mechanisms. 3 different types: resorption, compression, or contraction. So let's talk about compression first. So compression, that's shown kind of on the far right, is where you get these pleural effusions that come from a patient typically suffering from congestive heart failure, CHF. So this is a foreshadow to next week, because we're going to talk about heart failure next week. And just know for now, when a patient's in heart failure, there's extra fluid that ends up backing up around the lungs. And the patient complains that it's very difficult to take a breath. Just a big breath that feels good. They can't do that because they've got this compression atelectasis where the fluid is sitting in the pleural cavity and putting compression down. Now, another way this could occur in a non-congestive heart failure patient is with a pneumothorax. Does anybody know what a pneumothorax is? What's that?
Air.
It's air that's kind of on top of the lungs. Instead of that fluid, it's air, because usually it's from a stab wound or a perforation of the thoracic cavity, and then the pressures equilibrate between the pleural pressure and the atmospheric pressure, and now the lung actually kind of collapses down. So this would a pneumothorax, like from a stab injury or a traumatic injury where something pierces the cavity, is causing this compression atelectasis. Okay? Now, if we look at resorption, is where you've got an obstruction preventing air from reaching the distal airways. So something's caught in the airways and it won't allow it to inflate all the way. And then contraction, the bottom one, contraction is actually where the lung itself has fibrotic changes. You get scarring on the lung. And now the lung doesn't have its normal elastic recoil, and so you get this contraction type of atelectasis. Now, obviously, with atelectasis, the symptoms for the patient are going to be difficulty breathing, or no breathing at all, depending upon how severe it is, and then oxygenations of the blood as well as the tissues are going to be compromised. Now, if we move into our next category of diseases, our respiratory disease, we're going to break these into part 1 and part 2. We're going to call these chronic obstructive pulmonary diseases. COPD, chronic obstructive pulmonary diseases. Now, just the general category of obstructive pulmonary diseases, these are things that reduce airflow due to a partial or a complete blockage. Okay? It could be the tube itself, right? The bronchi itself are being influenced. And it's exaggerated with expiration or exhaling. It's not that it's not problematic to inhale, it's worse or more noticeable on an exhalation. So the types of obstructive are shown here, 4. Emphysema, chronic bronchitis, asthma, and bronchiectasis. So we're going to go through all 4 of them. Now, a subset of obstructive is what we call chronic obstructive pulmonary disease, COPD. And the word chronic just means that the symptoms are there long term. They never go away. So, like asthma, for example, asthma isn't typically referred to as a COPD type of disease because an asthmatic isn't always having an asthma attack. If they have an asthma attack, it's an obstructive pulmonary disease, but they're going to use their inhaler, their rescue inhaler, they're going to use an albuterol nebulizer, or they're going to go to the hospital and get a treatment with like a prednisone, most likely, or a Medrol type of steroidal to dilate out and reduce the inflammation of the airways. So an asthmatic doesn't typically live their life just dealing with the asthma symptoms. Does that make sense? So it's not considered chronic. Now, although this is new research that I just learned in the last year, there are a lot of asthmatics that are undertreated because it's just a little inconvenient, or they don't feel like it's that bad. They've gotten used to dealing with asthma, and so if they do a pulmonary test, there's actually evidence of chronic obstructive disease, and they're not being treated. So if you wind the clock forward 40 years of undertreating if you're an asthmatic and you just, I'm tough, I've learned to deal with it, I just fight through. It's not a good idea for 40 years to do that, because what ends up happening is you get a lot of the symptoms long term that are very indicative of what happens with chronic inflammation diseases, including increasing your risk of developing lung cancer. Okay? Yeah.
Is that with both like exercise-induced asthma or like allergy-induced asthma? Is it like different, or is it shown with both?
It's shown with all types of asthma that are under-medicated, that are under-treated. They didn't say medicated, under-treated. And so the patient is in a state of chronic symptoms, but they're just used to it.
Okay.
Does that make sense? And the best way to tell that is you do a FEV1 test. So you go and you do spirometry, you breathe out, and they measure how fast you, with the volume of air in the first second, and it creates a ratio. There's a magic number. And if you're below 70% in that first second, then you have an obstructive disease. If you're above 70%, then they determine that you're not symptomatic to the point where you need to be treated. Okay, so let's talk about the first one, which is emphysema. With emphysema, we're going to see some interesting characteristics, and we're going to contrast it with our second COPD, which is chronic bronchitis. And with emphysema, we get targeting of the alveolus, okay, or of the acinus, which is the alveolus as well as some of the surrounding respiratory type of tree that's capable of exchanging gas, right? So the sinus isn't just the alveolus, it's the alveolus plus the alveolar duct plus the respiratory bronchiole. All of these things are where these structures are part of the sinus, because the sinus is the functional respiratory structure where gas exchange can occur. And we lose the surface area of the sinus in emphysema. And you get what we call alveolar enlargement. And when you lose the surface area and you get this alveolar enlargement, you compromise the elastic recoil of that alveolus. And the loss of surface area is sort of difficult to appreciate until you kind of draw it out side by side. So if I have one alveolus that looks like that, okay, and I draw a second one here that's approximately the same size, but with less surface area. Do you see that? This one is the emphysema one, and by lowering the surface area, you've effectively lowered the structural tissue that can exchange gas. Okay? So when we say that you get this alveolar enlargement, it goes from this to this. Students think like, well, alveolar enlargement, I mean, if you enlarge the alveolus and you make it bigger, doesn't gas exchange happen better? No. It really stays about the same size. It's just that it kind of blows out. Okay? So it doesn't do this. It kind of goes from here to here. And now you've compromised gas exchange as a result of that. And so you can kind of appreciate in these cartoon drawings, right, what's going on. We've got normal right here. And this should be very familiar from 202. And then we've got this centra-asciner emphysema, which really affects, and this is the most common, affects the respiratory bronchioles. And we've got pana-asciner, which really affects the alveolus and the alveolar duct. And so you see how they kind of blow out, and you lose that surface area. This picture, I think, gives students sort of a false impression, because you say, look at this, and you go, oh, wait a second, that looks like it's bigger with more surface area. Well, draw it like this. I think I could have drawn a better job here than maybe what they showed. And I don't want you to get misled, because you look from here to here and say, wait, how is that less surface area? It almost looks like more. Draw it kind of like this, and then use that. Maybe the artist didn't quite capture it. The surface area really does go down. Now, with the two different types that we have, the most common being the centra-asciner, we see that this is mostly affected by cigarette smoke. It's very common for long-term chronic smokers to develop centra-asciner emphysema. Pana-asciner is more common in the lower lung. It is more commonly associated with patients that suffer from sort of a genetic abnormality. So let me explain. If centra-asciner is more common in cigarette smokers, it is really seen in the upper lung lobes, and pana-asciner is more common in the lower lung lobes, and is seen less commonly in patients that are smokers, more commonly in patients that have a genetic abnormality that make them predisposition for developing pana-asciner emphysema. Okay? So I'll explain what that means here on the next slide, but right now what I want to tell you is just be careful. If you move on and you're going to be treating patients, and a patient comes in, we all have made our own opinions about certain things. We call those prejudices, right? And sometimes they really are valuable and helpful, right? Like, wait a second, did you say being prejudiced is a good idea? Well, sometimes prejudging something is a good idea. It keeps you out of trouble, right? Right? I mean, if you're driving down an interstate and brake lights are going on, and you prejudge that there might be a DPS officer up ahead, and you decide to take your foot off the gas, in that situation, prejudging was actually helpful. So don't get caught up on the little word, right? But our prejudices that I want to talk about could be dangerous. For example, these are stereotypes. Stereotypes are also, sometimes the words that we choose, I like to point them out because they make people squirm, but it's just a word. right? And how you use it is important. But in your future careers, if you have a patient that presents with emphysema, don't automatically assume that they smoked their whole life. You could actually really open mouth and insert foot. And there's lots of patients that have Hannah Sinner emphysema, and they've never smoked their entire life. In fact, they're super healthy. There's no smoking in their family ever. Okay? So what's going on with these two different types? Well, the pathogenesis of emphysema, of course, we always start out with it's not clear, which is my disclaimer of I really don't know what I'm talking about, but I'm going to lecture for 2 hours. The field, we haven't worked everything out. We haven't figured it all out. Now we know that if you chronically use cigarettes, you're more at risk of developing central emphysema, which is upper lung lobes, and in kind of the respiratory bronchioles. But we also know that there is sort of this interplay, as this mechanistic slide is showing. There's this interplay between the remodeling that takes place at the level of the alveolus and things that will influence that remodeling. So for example, let's start with our chronic cigarette smoker. If we back up and we look at this macrophage that's in the alveolus, this macrophage could be turned on to increase elastase. That's an enzyme that breaks down elastin. If you break down elastin in the alveolus, you're going to lose the elastic recoil, and that's going to cause it to blow out. Right? And if you recruit the macrophage to make elastase and other matrix metalloproteases, it's going to digest away the structure, and it's going to go from this to this. Now, how do we get more macrophages into a lung alveolus? You guys tell me. What would cause more macrophages to show up within the lung alveolus? Inflammation. Right? I told you, I promised you, we'd be talking about inflammation the entire semester. Right? We're 2 weeks out. We're going to talk about it today. We're going to talk about it next week. Okay? So inflammation, I get emails back from old students who are like, yeah, I'm still talking about inflammation, Dr. Like, it's the clinical norm. It's in most every disease. So if we back up, we say, okay, inflammation, it's showing it as tissue damage. I would write a little word here and say inflammation. Our final is going to be cumulative. Well, you just answered a cumulative question right now, right? By knowing the tie between how we get more alveolar macrophages into the lung alveolus is by stimulating an inflammatory event. Well, there's a couple ways to do that. One is you could smoke for a long time and increase the number of reactive oxygen species and free radicals that come out of the contaminants in tobacco smoke. That's going to nicely increase inflammation. Well, in addition to that, there are patients that actually, from this side, there are patients that have a congenital deficiency in alpha-1 AT. This is alpha-1 antitrypsinase. Alpha-1 antitrypsinase. So what is this? This is a enzyme, alpha-1 AT. It's a elastase inhibitor. So we naturally have elastase in our bodies to break down elastin. And at the level of lungs, because elastin is so important for lung activity, we have an enzyme known as alpha-1 AT. And it blocks elastase activity at the level of the lungs to keep you and I having lung recoil capabilities for 70 plus years. Okay? Incidentally, the half-life of elastin in the body is about 70 years. So what that means is the gene for elastin turns off at about the age of 12. And then elastin composition starts to deteriorate. But when you're, say, 70 years old, you have about half the elastin in your tissues that you had when you were born. Okay, approximately. Or maybe 80, because it turns off about the age of 12. So, organs that have elastin, lungs, any tissue that does this, blood vessels that we're going to look at next week, skin, right? If you don't believe me, look at the skin of an 80-year-old versus a 12-year-old, right? You can automatically see there's a little less elastin in that one versus that one. Okay? Well, that's the organ, that's the biggest organ in the body. You can see it with your eyes. But all these other organs also lose elastic composition. Well, in our lungs, we have an inhibitor of elastase because obviously the design was to turn off the enzyme, but we want to make sure that the lungs last our whole lifetime. And so there's an enzymatic blocker. Now, there are patients that are deficient in this alpha-1 AT, and they are predisposed to developing more elastase problems that target remodeling of the alveolus. And so that's how these patients develop Panna center without any contribution from smoke, cigarette smoke. Now, what about the cigarette smoker that has the deficiency? Well, those are probably the ones that you see clinically very quickly. It was like, the perfect storm kind of thing. So how do you know? I don't know if there's a home kit for alpha-1 antitrypsinase, right? So always the two questions I get last week is, how do you know when the liver's like, like, I don't know, maybe you should develop a home kit, okay? Home kit for sales at college, universities, or primary clients to know, when, you should figure out, like, be like it'd be an app. Wouldn't that be nice? Like, ooh, the liver's at like 20% function. I'm not going out tonight, guys. You're not Okay, so the two main pathways. Tobacco, right, or the congenital deficiency, right? It doesn't mean that it's only one or the other. There's two different routes. That's the best understanding that we have of today. So now we're talking about cigarettes. So, okay, when I started lecturing, teaching this class, there weren't any e-cigarettes in this country. And there definitely weren't any shops where you could, you could go buy them and learn. Have you guys gone into any of these vape shops and asked questions? They're super knowledgeable. You should do it. It's fun. They actually know an awful lot about their product. I mean, they're extremely passionate about it, so they know a lot of information about it. But what they'll have a difficult time explaining to you is truly what's the safety of these e-cigarettes. And nobody can. You're like, well, wait a second. I've read a lot about it. Well, the FDA has decided that we don't know yet. So they're kind of like the paramount experts on this. So if the FDA still hasn't decided on the safety of these products, in fact, they've labeled it really right now as that it's not a safe alternative to smoking because the safety is yet to be determined. Okay? So it's not clear if they're safe. And I have a captive audience like we have last week when we're talking about liver problems and excessive drinking. Well, I mean, this is not necessarily considered a safe alternative yet. So how does it work for those of you that have never stopped the vapor guy and asked? Usually there's some sort of atomizer device, right, battery operated, because it's kind of weird to like cart around like a compressor or like a generator. That'd be kind of weird, wouldn't it? So they're battery operated, and the microprocessor within the unit is going to heat up a liquid, and that liquid usually has nicotine, but it's not just nicotine. The nicotine is turned into a vapor, and a lot of times, that vapor is to kind of, the psychology of it is so that the individual can actually gain that experience of actually seeing the vapor mist come out, and that kind of gives them that psychological connection to it's just like a regular cigarette. Okay? They don't have to make the vape. It could actually be nothing that comes out. You can heat it up and just have nicotine and not have any vapor. Like the vapor is all just for the look of vaping. Does that make sense? So that's kind of interesting. You can accomplish the exact same thing without the actual mist. It doesn't look as cool. So the problem is the samples that the FDA has actually tested actually do contain in their trace amounts of the same types of toxic chemicals and carcinogens that are found in cigarette smoke. Now, trace amounts, maybe nothing to worry about. But trace amounts multiple times a day, all day long, for 35, 40 years, maybe that is a problem. Okay, so we just don't know. Are they completely safe? Well, I mean, here's the bottom line: is probably nothing is completely safe. Something's going to kill you. I guarantee you that. Okay, so, but to falsely think that you're having an alternative that's completely safe is probably not a good idea. Okay? Do I personally think they're much safer than regular cigarettes? Yes, very much so. Okay, just by a number standpoint. Okay, it's a number standpoint. I mean, you're getting far fewer amounts of chemicals. But the problem with the vape now, question is, depending upon what the liquid is to create that vape, there may be new chemicals that we don't know anything about. Okay, like we know cigarettes, we have a long history of cigarettes as a nation, as a world, and we don't know yet about some of the newer vape technologies. I mean, my feeling is to make them really more safe is to get rid of the mist. And then you won't have a lot of these other things. And then you go into a chem lab and you purify the nicotine into a level that's actually really, really pure. So maybe a business opportunity is really safe e-cigarettes, but they don't have the vape. Okay? All right, so probably not a safe alternative as of yet. But you sure look cool doing it. Now, the problem with emphysema, the clinical features, and I love how we take these clinical pictures and we put like this little rectangle, like, dude, I have no idea who that guy is. Like, if you walked in right now, you're like, dude, who are you? Totally anonymous, because you got the box on his eyes. But this anonymous patient is trying to illustrate some of the classic clinical features of emphysema. Shortness of breath, that's the dyspnea. We call them pink puffers, because they typically have to force the air out. This is an obstructive respiratory disease, and so exhaling all the air out is complicated, so it's always like a... So they're working harder at exhaling, so they get a little bit pinker in the tissue. It's not because they're perfused better, they're actually perfused worse, but because they're exercising more, they have this pink tissue appearance. And in addition to that, they usually lose weight over time, so they're very thin, because they're exercising with every breath. They're working harder with every breath. Those are all skeletal muscles, right? You've got the diaphragm, you've got your intercostal muscles. For exhalation, it's the internals or the externals? Who said that? Internals, very good. Internal intercostals for exhalation, right? And you've got your rectus abdominis if you're really pushing, right? So these patients are exercising, so they usually lose weight. They're barrel-chested because a lot of times that expiratory reserve volume, it's about, 1 liter, and then the residual volume that's about 1 to 1.2 liters goes up, or the residual volume goes up, so it's like 2 liters of residual volume. So instead of everybody take a deep inhale, okay, and then only exhale about halfway, and then inhale again, and then breathe there. Do you see what's happening to your chest? So that's where they're breathing. They're breathing really high up with that tidal volume because they can't get all that air out. So the residual volume goes up. And it's as if they're breathing way up high, and that causes that barrel-chested appearance. Okay? Now, we want to contrast this with chronic bronchitis, and then we're going to take a break. So, chronic bronchitis, I like this slide because we've got one on one side and one on the other. If we compare them, emphysema is over here on the right, and we've got pure chronic bronchitis on the left, and it's usually not this clean. So let me just say that. So a lot of times, patients who present are going to have emphysema and will have evidence of bronchitis as well. Okay, but let's just, for academic sake, say that we're going to identify them uniquely independent for simplicity. Now, these chronic bronchitis patients usually have a persistent cough. Okay, the persistent cough, so now you can see, well, so you mean an emphysema patient doesn't have any cough? Well, they might, but the coughing is probably the bronchitis, not the emphysema. Okay? So the persistent cough usually is defined as a cough for at least 3 consecutive months in at least 2 consecutive years. Right? So it's not just a cold that hasn't gone away. I mean, it's been doing this for a long time. They usually have mucus present, but the airflow is not obstructed. 90% of patients that suffer from chronic bronchitis are typically smokers. And there's 3 main types: simple, chronic asthmatic, and chronic obstructive. The simple is mucus is there, but you haven't obstructed the airway. The chronic asthmatic is you've got bronchospasms that occur intermittently, and you have mucus present in the airway. Chronic obstructive, the last one, is the mucus is so thick that it obstructs that respiratory tree. And this is the one that you typically see in smokers, is the chronic obstructive. So if we look histologically at what's happening, I'm going to show this slide. So what do we have up top? What is that? Pseudostratified what? Ciliated columnar epithelium. Right? That's the normal epithelium that lines the respiratory tree. Now, there's been evidence to suggest as we move away from that lining that there's some environmental trigger. It's probably something in the cigarette smoke, the toxin or particulate, that triggers a gene known as the mucin gene, and that turns on and upregulates the production of more mucus out of the goblet cells. The mucin gene actually inserts more goblet cells into what would otherwise be a normal epithelium. It will have a higher presence of goblet cells, and that's where the extra mucus comes from. So you get enlargement or hypertrophy of the existing glands, and you get more of them showing up, and that's what creates an upregulation of mucus production in these patients. It starts in the larger airways, and then it moves to the smaller airways, and very, very often you're going to have infection that shows up as a result of too much mucus sticking around. Now, the bottom picture is an H&E stain, and this is a patient that suffers from chronic bronchitis. And what you're looking at here is the increase in inflammatory cells that actually show up. So if you can appreciate this border right here, this is your alveolus. And this is outside of the alveolus in sort of the parenchymal tissue of the lung. And from here to here, this to this, all of these purple dots that are in here, these are all infiltrated macrophages that have come into this zone. And this should all actually be fairly clear and open. So no purple nuclei should be present within that particular H&E picture. So what do these patients look like? Well, again, back to our previous example, we'd never recognize this person because they have the box across their eye. But the clinical features, and the clinical features here are very difficult to separate out from pure emphysema because most of these patients have some evidence of emphysema and chronic bronchitis. And so what we're seeing here is patients that have both emphysema and chronic bronchitis are going to exhibit these characteristics. We think that much of it is due to chronic bronchitis because emphysema in its purest form looks very different. But these patients are blue in skin color. They're cyanotic. And they're cyanotic because they have really the inability to move the air quick enough to actually oxygenate. So it's very common to see them both together. I've already said that numerous times. These patients will have cough with sputum or spit up. So this is considered a productive cough. Right? Did you ever wonder what that term was? Like, was your cough productive? Like, I don't know. What do you want it to do? Productive cough means that you cough and something comes up. Okay, so if you get really sick with a respiratory cough, you know that's kind of seal bark, like that, right? Nothing's coming up. And then as it kind of goes away, it kind of breaks up, and then you're like, you're around, you're like, oh, I'm getting better, really. So that's the productive coughs when you get the sputum. These patients have shortness of breath upon exertion as they try to, not run, but like walk up a flight of stairs, for example. Okay? All right, so let's take a break here, and when we come back, we'll pick it up with part 2.